through, and that might help them as they are trying to get through their depression. Another thing that might come up with someone with a mood disorder, they might speak about wanting to end their life, about wishing that they weren't alive anymore. And I want to encourage you all to talk to people about this if they bring it up, not to shut down that conversation. Suicide is preventable. There are many resources out there. There's the 888 hotline, which is later on in the resources I gave you. Some organizations, and I think it was the National Institute of Mental Health, that last one, which has the suicide prevention hotline number on it. So in addition to having these external resources we can go to if somebody's expressing suicidality, we can also hear them express what they're feeling. If someone is saying that they don't want to live anymore, rather than just trying to shut it down because that's a very scary topic, they've been thinking about it. If they're talking about it, they've been thinking about it. So we can be someone that they can talk to about it just by being open and asking some questions. You don't have to, if you're feeling out of your depth, certainly reach out to another professional. Encourage the person that you're talking to call the hotline with you, or you can go with them to an appointment or call a therapist with them. But it's not going to make things worse to ask them, how long have you been feeling this way? Have you thought about this before? Do you have any plans to hurt yourself? If they say yes, what is that plan? That's a very dangerous situation if someone has a plan, especially if it's executable. If it's well, I think I might go get something and they don't have it yet, that's a little bit less dangerous. I mean, it's still dangerous, but it's a little less imminently dangerous. So just being open to asking these questions, to hearing what they have to say, and then staying with that person to seek help or getting help on their behalf. So I just want to encourage you that if someone brings up these feelings, or feeling just a passive, what we call passive suicidality, I just don't want to be alive anymore, you're someone that someone going through this might want to talk to about this, and that you can talk to them about it. I just wanted to lift that up. I want to say a little bit more about bipolar disorder. Somebody who has this diagnosis may be very excitable. They may talk a lot, and they might need some help structuring what they're saying. And when I have patients who have this diagnosis, I try to encourage chaplain interns. It's okay to interrupt them because they may not even know where they're going with what they're saying, and it's okay, and it's actually helpful to them if we can provide a little structure. Okay, you've talked about this, and this, totally unrelated things. Which one do you want to focus on now? So that's one thing you might encounter with somebody who's especially in more of a manic phase. Are there any questions about this first section of mood disorders? Yes?
I kind of have a question about our role as pastoral caregivers. We accrue a certain amount of experience and maybe have seen certain treatments that are helpful, but I'm always really hesitant to give any kind of advice or guidance. If someone says they're about to get something, I might speak to, I have seen that be very successful, you should go in with some optimism. But I'm thinking specifically, I know it's not called this anymore, but the electroshock therapy, has a new name.
ECT.
ECT. Last 5 years, I've seen several people who that was the one thing that brought them out of their depression, who multiple hospitalizations, no cocktail medicine worked, but that really worked. And so if I've had parishioners who have been recommended that, I can speak positively of it, but I've been hesitant of some parishioners who are going through multiple hospitalizations, nothing seems to be happening. I don't want to even broach that subject of recommending something. Is that really inappropriate for us to do, or is there a pastoral way to say maybe you should talk to your professional about ETC?
Yeah. Go ahead, Susanna.
Please let me say something, and I know that you all will probably cover this in your presentation later, but I do want to make it very clear. I think we probably all learned this in CPE or seminary or however we were trained as clergy. We are not therapists, period, the end. We cannot go too far. We're there to listen, if we know of things and of other resources that would be able to give more specific information or advice or counseling, that should really be our first mindset when we're listening to somebody who comes into our office or having coffee or whatever. Our goal should not be, how can I myself, all by myself, help this person over the next 3 months, 6 months, 1 year, 5 years. It should be, how can I direct this person to a qualified professional? You are a qualified professional. You are a qualified professional. Some of us have other degrees that help us in what we do. However, if we are pastoring a parish, we are not therapists, counselors, social workers. We are the pastors and priests of that parish. And our work is not to say, I'm going to stay with you through this issue to the very end, because you're not. And I know you all were going to get there, but I don't want us to get too deep into the therapeutic aspects of pastoral counseling without saying it stops after 3 times. That's the policy in this diocese, correct? I think that's kind of boilerplate for most parishes. 3 times is what you get to really get in depth with somebody. So at the first time somebody wants to meet with you for pastoral counseling, you should have a mind to say, where do I send this person after appointment number 3? If it's something like somebody died in their family and they want to come talk to you, you don't have to boot them out of the office to a grief therapist. But you might need to. So before we get into, I'm going to send this person or recommend a certain kind of therapy or medication, no. Before we get too deep into that,
let me just clarify. Like,
yeah, go ahead. I'm sorry if I took that away from y'all, but I just wanted to get that out there.
Right, so just to clarify, you have a parishioner, you're following those guidelines, you're not being their therapist, right. They're in treatment, but there's been multiple hospitalizations, and you've seen a therapy that has been successful, they haven't brought it up. It's one thing to direct them towards a mental health specialist, to encourage them to engage with that. Doesn't cross a line to say you might want to ask them about this specific thing.
Yes.
I mean, I think that there is a trick here. Maybe you've already done this trick, which I use all the time because as a chaplain at the psych hospital, I'm not recommending therapies or anything. However, I can ask them, what therapies have been recommended to you? What have your doctor told you about? What have you heard other patients talking about in the hospital? And let them voice what they've heard about what they might know, help them try to explore their path because it's their life, it's their experience. I think it is really tricky because you may have seen several people really have great experiences with ECT, and maybe you think this could be the thing that could help this person, but coming from you is not the most appropriate. Now, are there other ways you can try to encourage this person? You could be part of their treatment team. So this is a thing of the psych hospital treatment team. So it's a little less clear out in the community here, but perhaps if the parishioner is open to it, you can be in touch with their therapist. You can tell their therapist, have you tried this with this person? Has this been suggested to them? As a non-mental health practitioner, this seems to work really well in people I've known. And so you could talk to the therapist. That way, if it is appropriate, the therapist can recommend it. Or the psychiatrist. Even when in a hospitalization, you can go visit, if it's allowed, if the person agrees to it, you could visit them in the hospital, or you could talk on the phone to their caregivers in the hospital. The caregivers might say, I can't confirm or deny the person's here if they haven't signed consent, but they can take information you want to give them. They can write it down. That's what we do all the time. Somebody calls in, they haven't signed consent, but they want to tell me information about this person who I know is here. I'll take that information. So you can certainly work with the other people on the team, whether in the community or in the hospitalization process, and let them be the ones to figure out whether this would be appropriate for this person. Because with ECT, at least at Trenton Psych, that is, if all other treatments have failed, it's a last resort sort of thing. And it can be problematic if somebody hears about it, but they're actually stable on their meds, and they're like, oh, I want to try this new thing. It's not appropriate for that person to try.
Yeah,
so,
I'll make clear,
yeah.
I never recommended or
Right.
suggested it because of those very reasons.
Yeah.
I just wondered if there's a way of nudging or encouraging, and the only time that this come up really is oftentimes parishioners before they get an And so I don't say, hey, I have no medical expertise, but I have seen people who have had it done.
Yeah.
It has been successful. It is very different than what we visualize from pop culture. And just giving them that kind of a little bit of relief from an outside party to say,
Yeah.
you don't have to fear stigma.
Right.
You know, that's been my conversations. I've never recommended it.
I just wondered if, like, you see someone being hospitalized,
I think
being
you're
on
gonna have to
suicide
go
watch.
through. If you're gonna go a roundabout way for that. Yeah, Bishop.
To say, I think you have to be very, very careful to be recommending any kind, and then starts to edge into that. You know, I think that in my pastoral ministry in the congregation, one of the most valuable things I did was develop a relationship with local psychologists and therapists. And if someone came to me with something like that, I'd say, I've known people who experienced that. Maybe you want to go talk to someone. Would you like a referral? And just refer it on. And, you know, anytime we're getting to the place of diagnosing or coming close to it, well, in a sense you are, because you're saying, well, it's very urgent.
I think what's motivating my question is I'm wondering if, because of the experience, that they've had that stigma and they've already moved it out of their mind. And I almost want to open that pastoral conversation. And like I said, I really want to be clear, I've never given that recommendation.
But I had somebody you may be able to talk to about it.
Yeah.
You know, and then send them to the professional.
You just feel like I don't want to broach that subject.
Yeah, I think you really have to let them bring it up, but you could always ask the question, like, are there any treatments that anyone's recommended to you that you're hesitant about? Because what we can help someone do is go through this process of just naming their choices we're not saying you should do this or that, but we can just be that sounding board while they're just talking about a decision they're trying to make. But yeah, any sort of actual like recommendation, I think we got to do a roundabout way, but I think we can do that. Like, I think it's great. Like, if there's a pastor in the community, even though I'm a chaplain, if there's a pastor in the community and I have their parishioner as a patient and that patient has their support, that is so great. Like, that is so helpful for somebody in their recovery. Is there another question?
Not talking about treatment, we're talking about alternative support networks like Al-Anon, AA, those kind of recommendations. Then we get into this weird gray area of, can I say, as someone who's benefited from Al-Anon and is part of that community in my own spiritual life and my own personal mental health journey and my own whatever, to say to somebody, I'll go to a meeting with you, is different than saying, I'm just clarifying, like, because to say, I'm going to help you go to treatment, we're talking those three, this is where it becomes fuzzy to me, of like, if it's pastoral care and there's 3 sessions on a topic, and then we're supposed to refer somebody out, if it's, and this is personal, if it's a beneficial practice for me to go to Al-Anon, based on my family history and my experience, to invite somebody to a meeting is not the same as continuing pastoral care. And so,
Well, no, because Al-Anon is a peer-based, it's a peer-led experience.
but I'm saying, like, this is where it gets fuzzy for me, because then you're no longer, because if I'm inviting them to my meeting,
Well, that's something you're going to have to decide. You might want to find another meeting to invite them to.
But I'm saying, like, that's where my question mark is. Like,
Yeah.
You have the freedom to go to, like, literally thousands of meetings right now.
Yeah.
But how do you navigate that to say, because I also can't control you not coming to my meeting. If it's the meeting that works for you, it means in the same community. And there's an out that's anonymous, and I understand that.
Yeah, I would consult actually with your meeting about that, or a sponsor or fellow people in your meeting, because that to me gets at the issues of anonymity that are part of Al-Anon, because it's another spiritual program. So, and I think for you personally, that would be something to work out with the people who are part of that meeting. I don't see that as like something the church has like an edict on personally, but maybe like Bishop French will contradict me.
I want to echo the caution around this.
I think there's a difference between pastoral care and therapeutic relationships. I think you know that. But it's helpful if we can clarify for us where the boundaries are. There's some technical things like the 3 appointments and no more. But there's also the reality that we are there to help people
people to find Christ in the midst of difficulty in a very tangible way. And we can do that by offering the ministry in our church. It's not our own ministry that we carry, it's the reality of the ministry that has been entrusted to us. When it gets questionable, and there are times when our personal journeys become part of what we can offer, and a gift and a strength for the work we're doing. But when it comes into a place where the boundaries are unclear, that's a great opportunity to bring it into conversation with a mentor or a senior clergy person who can speak with you through that and help you to figure out the best way forward for yourself, for the person you're caring for, and for your congregation.
I think, too, again, just to echo what both Bishop Stokes and Bishop Friend said, I mean, the thing about it is, for me, again, the caution is we're here to encourage, support, as Bishop Friend said, point to Christ, but at the same time, there is that thin line that, again, where we have also to consider next of kin or family members, and that sort of thing as far as the pastoral care, where for us, we have to also be careful of where we step. Because whether we like it, realize it, however we want to frame it or not, our words carry weight to people in their times of need. And so we have to even be careful as to, quote unquote, leading questions and leading suggestions, because again, one, has been stated, we're not counselors, we're not, unless we're trained in whatever else, and even then we're supposed to, in a sense, be in a different capacity. And so the idea of, again, 3 and done, if we have to find ourselves getting to number 3 is the understanding of the person, is, to me, the understanding to say to the person who may be coming back, when we get to the 3rd meeting, or next time, I'm going to suggest that these agencies, people, whatever, because again, we don't want to get dependent, and even if we know as difficult and as hard-wrenching as it may be sometimes for us on the pastoral level to kind of take our hands off, there comes a time when we have to realize for ourselves it's time for me to take our hands off. It's time for me to kind of sit and say, I suggest that this is the route, and allow, again, formulate a list of agencies that we may be able to say, hey, I think this is helpful, maybe help you, and be able to admit to them, I don't think that there's anything else that I can offer.
Yeah, I'm going to be a little contrarian here, because I think that sometimes it can feel like we're being told, no, 3 and done, you can't talk to them ever again after that. Well, I mean, they're your parishioner, right? They're coming to your church. There's a lot we can do as priests. The sermons we preach can be very informed by what our people are going through. I mean, they should be very informed by what our congregation is going through. In those short interactions during coffee hour, the ones that aren't the formal sit-down sessions, we can still support someone. So I just want to balance out, because it is an important message, but it's also, I think, makes people think like, I'm limited. But actually, there's a lot of freedom in everything else you are allowed to do, and what I would hope that you would do. Just the way, like the short interactions, what I do on my units of like rounding, like the 5-minute, 10-minute conversations, the short ones, not the hour-long sessions. So just to balance out, like if you're feeling stifled, like, I can't help people. You can help people. We're just saying with all of this, like there's a limit to those formal sit-down sessions, but they're your parishioners, so you can have an influence on them. Yeah, one more question, and then I'm moving on just for the sake of time, and then we'll have more questions later.
I just want to say, I found coaching to be very helpful in pastoral care, because you're not the expert, you're not the mentor, you're asking open-ended questions, and you're walking alongside. And I've had parishioners, so I've done the diocesan level coaching as well as advanced coaching training, and I've had parishioners who really just needed, they were processing what they were going through, and they needed somebody outside the immediate family system who wasn't going to judge them or the other family member involved. And so coaching was a really helpful way of walking alongside without feeling like you were directly, to me it's a form of pastoral care that has enough hands off. And in a number of cases, when I've offered it to people in the community or otherwise, they have parishioners, they have therapists, so like they have other people working with them, and it's just a way of them identifying like the next best step for them. So I found that that's like a very healthy sort of, there's boundaries built into the format of it, and it's always clear that it's not therapy, and that's not what's going on.
So moving on with some other common mental health diagnoses you might encounter in your parishioners is thought disorders, also known as psychotic disorders. These are psychiatric illnesses characterized by abnormal or disorganized patterns of thinking and related behavioral or motor symptoms. So some common ones are schizophrenia and schizoaffective disorder. Schizophrenia is characterized by the presence of delusions, hallucinations, and or disorganized speech that significantly limits functioning in daily activities. So some people sometimes get confused, delusion, hallucination, what's what? A delusion is a non-reality based thought, and a hallucination is a non-reality based sensation. So if I believe I am the Virgin Mary, that is a delusion. If I think I am seeing or hearing the Virgin Mary, that's a hallucination. And hallucinations can also involve sense of smell, taste, and touch. All the senses can be part of that. I'll get to your question in one moment. Schizoaffective disorder is characterized by the presence of both psychotic symptoms, so the delusions and hallucinations associated with schizophrenia, and a major mood episode, either manic or depressive. So that's someone who's got a lot going on for them, both in terms of non-reality based experience and a major mood experience. So some things that can be helpful for pastoral care for folks going through this. Just to keep in mind, they may say things that don't make sense. They may give you a long story that's very difficult to follow. They may not trust you or other people. I mean, if you think about it, if you can't trust your own thoughts or your own senses, can you really trust somebody else who's external to you? So that's why paranoia often goes alongside this. They may believe that they are a religious figure. They may have tics or idiosyncrasies, like just like moving their arm in like the same way that's not they're trying to hit you, perhaps. It could just be part of their mental illness. And they may have persistent delusional beliefs that continue even after they're on a therapeutic level of medication. So even after they're stable, they still might believe they are God or whatever delusional belief they might have. So one thing that's really helpful for me when thinking about working with people who are having non-reality based experience is to think of that as kind of like a corollary to like a medical condition that we can't change or a life event we can't change. If somebody goes through a car accident, we can't change that car accident. If somebody is having a non-reality based experience, we can't change that non-reality based experience. But we can help them talk about what is it like that you went through that car accident. How is it for you to live with these thoughts, with hearing that voice? What is the emotion that they're dealing with in the moment? And trying to help support someone with what they're going through right now. Because that is something that is very reality-based that we can work with. Emotions are always reality. It's always a reality. There's no hallucinated emotions. They're all real. So we can work with any emotions. We can work with how this fits in with their spirituality. Or just their life experience. If someone thinks they're Jesus, then they might experience that other people don't believe them, that other people ridicule them, that it's like a secret, or like they may feel like they have a secret mission from God. So we can just talk to them about what that experience is like for them. So those are some general tips I have about thought disorders. There was another question?
I wanted to differentiate. I see a lot of folks with PTSD who dissociate, and I think there can be oftentimes overlap and confusion around hallucinations versus dissociation, and so just something that might be helpful in differentiating those two is if someone's hearing voices internally to them, that's oftentimes a dissociative state. If it's an external voice, that's a hallucination.
That's an interesting distinction. I've actually never heard that before. So thank you.
I ask everyone to hold their questions. I want to go through
The personality disorders on this first page, but then I'm going to ask Greg to come up and talk about this from a uniquely parish pastoral perspective. This is valuable information and we need this, but I also want to make sure we have time to cover what this might look like in a parish setting, because I'm not equipped to work the way that Allie works. I'm so grateful that she does what she does. I hope I see milder or fewer forms of this in the parish, but I want to know how to deal with it when it happens. So can we finish up the personality disorders on the first page, and then I'll ask Greg to come up and talk about this from a parish perspective, if that's all right with everybody. Okay.
Yeah, so I'm hoping that what I'm saying does have resonance for you. I'm not trying to give you, like, this is how to be a psych chaplain. Like, I know you're all priests. I'm trying to help you in your parish setting. Okay, well, we'll get there in a minute. So personality disorders are psychiatric illnesses characterized by pervasive patterns of thought and behavior that deviate from cultural norms and cause significant distress or impairment. So important part here is noting that cultural norms are part of it. This is not a brain condition that we can treat with medication. Personality disorders, it has to do with what's normative in a culture. So there may be a culture in which something is very normative, and yet in other cultures it's a problem, it's problematic. So I think amongst certain business executives and CEOs, there's certain normative behaviors that the rest of us think are terrible and disgusting, but we'll get to that. So antisocial personality disorder is characterized by a pattern of disregard for and violation of the rights of others. This is not when you're feeling like you don't want to go be around people because you want alone time. That's asocial. Colloquially, we say, I'm feeling antisocial. I don't want to go to the party. Well, unless you want to go rob a bank, you're not feeling antisocial. You're just feeling asocial. So antisocial is against society, where you don't care if what you're going to do is going to harm someone else. You just want to do it, and that's what you're going to do. So a lot of people who have legal issues might have antisocial personality disorder. Borderline personality disorder is characterized by a pattern of instability in interpersonal relationships, self-image, and affect, which is emotional expression, as well as marked impulsivity. So someone with borderline personality disorder will have a lot of difficulty with their emotion regulation. So if you are into sports or go to a party and there's a lot of excitement and you're part of the excitement and you're cheering, and then the moment ends and you calm down and you just chat with your friend, that's you regulating your emotions. You were just really excited and then you calmed down. This is something that most people learn how to do. It's a skill that you learn how to do as you're growing up. But some people, because of an abusive environment or because of trauma they've experienced or some sort of invalidating environment growing up, they don't learn these skills because they were trying to survive. Perhaps what they learned to do to control their emotions was something that we would see as very problematic. They hurt themselves, or they escalate in some way and destroy things. But for some reason, that calms them down. Well, that's not very skillful. It might sort of work in a way, but there are better skills out there. And so there's actually treatment for borderline personality disorder that's been studied and shown to be very helpful, which is called dialectical behavioral therapy, or DBT. That's something that we offer at Trenton Psych, and I've been able to do some training in that at the psych hospital and do some work in that, and I think it's great, and it has a lot of resonance with pastoral care, actually, and just generally good approaches to have with people, which is to validate them and their experience. Even if some aspects of what they're talking about you wouldn't want to validate, like hurting themselves or punching someone, you can validate that they were feeling very upset and frustrated and didn't know how to deal with it. We can validate that. Then we can say, and punching that person was not effective. Or, and hurting yourself was not a long-term solution. So in dialectical behavioral therapy, there's all these dialectics, and one is between validation of the person and change. So we validate them, like that unconditional positive regard. You are wonderful. You are a good person. What you're going through is something that is really relatable as an individual. Your experience makes sense. The distress you're going through makes sense, and you need to change. And you need new skills and new ways to act and behave in the world. So that's my little DBT spiel, because I think it's great. And I think there are principles of DBT that anybody can incorporate. Like just validating somebody's experience is good pastoral care. But someone with borderline personality disorder may be very confusing to relate to, because one minute you're their best friend, and the next minute they hate your guts. And it's like, what did I do wrong? Well, you didn't do anything. This is part of their dysregulation and their instability in interpersonal relationships. And lastly, narcissistic personality disorder, characterized by a pattern of grandiosity, need for admiration, and lack of empathy. So one thing with narcissistic personality disorder is we might think, oh, that person's so full of themselves, they think they're hot stuff. Actually, they don't think that about themselves. They probably think they're garbage, which is why they need everybody else to constantly tell them that they're great and wonderful. There's that need for admiration from the external because it's never filling that void of a total lack of self-esteem. Another really important thing when working with someone who has even traits of personality disorders, maybe they're not diagnosed, but like they kind of act in a way you're like, oh, this is not how people usually function in society. Boundaries are very important, being consistent, and if they try to push your boundaries, being steady on your own. That's really important for someone who doesn't have the ability to make their own boundaries. If someone else provides it for them, they might resist that, but it's actually really helpful for them. And also, like I said, validating emotions and experiences without validating the invalid. So you validate the valid, not the invalid. And remember that how someone is acting, no matter how dysfunctional it might seem, there is a purpose behind it. Like it's doing something for them. Even if it's really ineffective, like there's a reason they got there. It's not just because they're trying to be jerks and ruin your life. Like they have their whole history and background. And I think that's really important to remember and keep in mind when someone's pushing our buttons. And there's a really high chance that if they have a mental illness, that they've endured some sort of trauma in their lives. Even if it's just the trauma of having a mental illness, that can be traumatic for people. So keeping that awareness in mind can be really helpful when we're trying to help somebody and they're making it hard for us to help them. So my general conclusion is people with any of these things going on, they're our neighbors, they're your parishioners, they're your family members. And I hope that when my patients are discharged, which most of them will be, and they go out into your communities, that your church will be a welcoming place for them. That they will find a community that will welcome them and include them and try to love and understand them, even if they're going through a very difficult time that can kind of leak out and cause a little bit of chaos. I'm hoping that I'm giving you some tools and hopefully some of these resources that you can look into later to increase your ability to have a loving community that includes these people. Because these people are dear to my heart, so I want them to be dear to yours also. So just like some final general attitudes, seeking to understand where somebody's coming from, listening, don't judge them as bad. Even if they've done bad things, try to keep those two things distinct in your mind. Act out of curiosity and love. Show them welcome, and you can do that generally. You can also reach out to programs in your community to try to be involved. Maybe there's a group home, maybe there's a program that would welcome your church to do some sort of program with them. We used to have that at Trenton Psych, where churches could come on site, and many Episcopal churches did. We don't have that anymore on site, but you can participate by creating a video that we will show to our patients of a church service. So if you're interested in that, please let me know. My email address, as well as the other members of the committee who are here, is on the bottom of your resources page, so please do reach out for that. Greg and I, we're going to talk a little bit about autism and substance use, but maybe we'll leave that to the side because it's not our expertise anyway.
All right, thank you. So thank you for presenting that, Allie. When I was in social work school, one of my professors said, when you get out there into the field, you're going to be dealing with much heavier and higher levels of mental illness than therapists have dealt with in the past. And part of that has to do with the way our healthcare is in this country. It had to do at the time, and still has to do with the way the economy is in our country as well. And I think perhaps the sort of summation of all of this as clergy is that in our parishes, I think I can imagine if it's like the parishes I've served in, you're also seeing much higher levels of mental illness in our society, especially having come through a pandemic. So our hope in sharing these three categories of the mood disorders, the thought disorders, and the personality disorders is just to give you a breadth of what the kind of landscape looks like. It's not to have you diagnose anything, but to give you just sort of a sense of what the landscape of possible mental health disorders you might encounter in a congregation. Again, I'm going to talk in a minute about referring, but again, this is not your role to diagnose these. Please don't look at that piece of paper and say, oh, you have narcissistic personality disorder. You are not qualified to say that. So that's really important that you not go there. I can tell you as a therapist, it may take me a year to decide if somebody has a borderline personality disorder. There may be a whole bunch of other things that it might look like. PTSD, somebody might be coming out of extreme alcohol use. Both of those things look exactly like borderline personality disorder. So don't go there. But just kind of know that these are sort of the sphere of possibilities that are out there within the lives of congregations. The one thing I do want to hit on that we didn't hit on, autism I think a lot of folks know about, and in fact I'm going to step aside from that and just let you do your own research on that. But the one I think that does impact us the most in the church are what we used to call alcoholism or other substance uses. We moved on to referring them as substance use disorders. And the reason we don't say that person's an alcoholic anymore is because that's a very labeling kind of action that we might be doing. We say that a person has a substance use disorder because the more we know about these, the more we know that there's a real organic brain chemistry element that goes along with substance use disorders. In the Episcopal Church, we have a long history of having a very liberal relationship with alcohol. It is what it is. And it's something that we have to be really aware of. So one of the things that you have on your table that I printed out for you, and again, this is not for diagnostic purposes, this is just to get you thinking, because this helps me when I think of somebody, I think, oh, I forgot about that kind of category. Often I'll hear somebody come to me and say, oh, that person's a functioning alcoholic. Have you ever heard that before? They're functioning alcoholic. They're going to work, they're getting their job done, but they're getting drunk every night. They're not waking up with an eye-opener. They're a functioning alcoholic. But you know what? There are all these different dimensions
The QR
to
code
alcohol.
on your screen now
Where
will allow
somebody
you
who
to
looks
download
like a
this
functioning
handout.
alcoholic, and that's not a technical term, that's just sort of a colloquial term, somebody that looks like a functioning alcoholic, we might want to kind of look at some of these other kind of elements of substance use disorder or alcohol use disorder to kind of get a more full picture. And just for your internal processing, when you see a parishioner and you see some of the behaviors, that you see, these are some categories that might be helpful. And you can kind of see at the bottom there's mild, moderate, and severe. And those, that's how we kind of put it on the spectrum of where somebody is with substance use disorder. I'll bet as you look at some of these, some of them jump out at you like, oh, that reminds me of like Joe, or that reminds me of somebody in my family, because they're nuanced, and so these are just some good categories for you to have in your head. The only other thing I would say, there are three others I want to touch on. So it turns out that cannabis is legal in New Jersey. Did anyone know this? Nobody knew this, right? Okay. Cannabis is legal in New Jersey. You can't get addicted to cannabis, right?
Oh, that's all impatience.
You can't get addicted. Nah, you can't. You can get dependent upon cannabis. You can get dependent upon cannabis. It's important to know that. So do be aware that that's something we're seeing more and more people seeking out treatment for cannabis use disorder. So it's something that you want to be aware of with your parishioners. It's something you want to be aware of if you choose to use yourself, whatever, that's just something that folks don't always know. The other two that you're probably likely to encounter that are really above your pay grade and you really need to immediately refer out to, opiates for sure. I think we all know about the opiate crisis. But the other one that is a real kind of slippery one is the benzodiazepines. So you're looking at your Ativan or your Xanax. These are medications that doctors will prescribe to sort of calm folks down. I think of the benzos as like pill alcohol because they work in the same pathways as alcohol does. And they are much harder to get off of than even alcohol. They really require a very, very specialized treatment. So just be aware that if you have somebody who's talking about like, I took my Ativan again, or Xanax is the one, big one that's really dependent causing, that they're gonna probably, be looking at something that's a little bit more serious in their treatment. That's something just to be aware of. All right, I do want to circle back around to the referral piece. And I just had this sort of one thought to kind of wrap up, and I'm going to invite Alan up in a second to talk about self-care. But in the social work world, we have a code of ethics. I always thought like the church should have a code of ethics for clergy, but and maybe that's something somebody wants to work on. But in the National Association of Social Workers has a code of ethics. And the one that I think, the point that comes up, I think, more than just about any ethical point in the practice of social work is the term avoid dual relationships. Avoid dual relationships. It's really important. Would you use your parishioner to be your financial advisor? Would you use your parishioner to be your car salesman? That's a dual relationship. I think from a pastoral standpoint, even beyond mental health, I think that's something that we really need to be aware of, dual relationships. But the reason it is really important with regards to mental health is when I see a client in therapy, that is a very boundaried setting. They don't know if I have children, unless I choose to share that. They don't know where I live. They don't know, if they text me after hours, I'm going to say, let's talk about that at the next session. I'm not going to text them back. They don't have any kind of connection to my employment, like what if they're on the vestry, for example. And so it not only puts you at risk, so certainly to have like this relationship where you're kind of walking along with somebody through their treatment, it also puts them at risk. Because the boundary is important to the therapeutic process. For folks to do the work between the sessions, sometimes I confront clients, and that ticks them off. That's not something that you maybe are able to do in your ministry setting. So really the role is to really think about, am I getting into a dual relationship here with regards to helping somebody through their crisis, or whatever it is that you might want to think about instead referring them for. It's something to really just keep in mind there. And then finally, I want to wrap up this question and just sort of sum all of this up. One of the things that we know about humans is that we are wired to connect. When you connect, when I smile at Susanna, she smiles back, right? Like, because why did you smile back? Because that's right, we're wired, and brain chemistry goes as far as we are wired to connect. Connecting with other people is what makes us healthy. And that is something that we can offer in the church in an appropriately boundaried way. So when that person comes and says, I'm going through this big thing, we can listen, and that is helpful, and the connection with the community is really helpful. One of the first things I ask somebody who comes in and says they're depressed is, well, tell me about your friends or your family. And more often than not, that person will say, well, I've got a bad relationship with my family, and I don't really have any friends. And so that's part of the process of helping them to get out of that mood or that stuckness is helping them to connect with other folks. So just keep that in mind. That's really where you can be the hands of Christ. That's what Jesus did. He reconnected those who were left out of community. And that is your pastoral role with regards to mental health. I'm going to hand it over to Alan. He's going to talk a little bit about self-care.
Thank you. For those who don't know me, I'm Alan Leonard. I'm rector of Church of the Advent in Cape May. The uniform I'm wearing is volunteer part-time stuff I do with the Coast Guard Auxiliary. If y'all like to be involved in the Coast Guard Auxiliary and do chaplain support to the Coast Guard, talk to me afterwards, send me an email or something. Love to talk to you about that. But today you heard some good information about typical mental illnesses we might find in our congregations, a little bit about substance abuse and the boundary issues. What I want to ask you to do is switch your thought a little bit and say, how are you doing yourself? Are there things in your life that are concerning? If you looked over that checklist of alcohol and substance issues, you're going, I didn't check off a few of those. Maybe there's something I need to look at and pay attention to. Because while we are here to care for our parishioners, we also have to care for ourselves. We have to make sure that we are able to have ourselves in good order so that we can care for the people that we serve. It's important to be self-aware. Know what's going on. Know when you're upset. And echoing what Bishop Stokes said earlier, I spent 5 years as the president of the Ecclesiastical Disciplinary Board in the Diocese of Upper South Carolina. And yep, 100% of the clergy facing Title IV complaints isolated themselves. They were doing that Lone Ranger thing, and they got in trouble. 100%. That was the root of those problems. So, we need to make sure we don't get isolated. The whole purpose, one of the main purposes of Fresh Start is to connect you with each other so that you know that you have clergy friends in the Diocese of New Jersey. It is important that you have those colleagues. And once you graduate from Fresh Start and go off, you still have to stay connected with people. Find the other clergy in your neighborhood. They don't even have to be Episcopal clergy. I've got a good working relationship with Roman Catholic clergy, United Methodist, Presbyterian. We get together regularly. That's important. Maintain those connections. If you don't have those connections, get those connections. Have groups of people you can sit down with who understand this strange work we feel called to in ministry. Because it is different. It's what a lot of people are doing, and we need to have people we can talk to about these things. And I've had really good clergy support groups, ecumenical groups in Cape May where we meet on a regular basis. The Diocese of New Jersey has things to help you out. We've got affinity groups all over the place. So Canon Joanne Izzo can talk to you a lot about affinity groups we've set up. I've set up one recently for chaplains. So if you're doing chaplaincy, fire department, police, whatever it might be, I'd love to have your email and provide a monthly affinity group that meets via Zoom to talk about those things. Those connections are vital. Spiritual direction is a form of self-care. I have just started with a new spiritual director. That's important. It's a place where I can talk to someone, I can work on my own spiritual growth. Because if I'm spiritually tapped out, I am no use to my congregation. I am not able to help them. So that's important. The diocese has clergy coaching and mentoring programs. Look into those. Especially if you're new in ministry, look into having a mentor or a coach. If you've been doing this for a while, look into becoming a mentor or a coach. Those things are other ways we connect. Now, how many of you are a member of the Church Medical Trust for your health care? How many of you've got that card here? Pretty much all of you, right? You know, if you take your card out of your wallet and you look on the back of your card, there is a 800 number at the bottom of the list of all those numbers you can call for EAP. Okay? That is an Employee Assistance Program. I have taken advantage of those folks on several occasions. Call up that 800 number, talk to them, and I don't even have to give you a resource because you should be carrying that in your wallet. The EAP program allows you 10 sessions with a licensed professional counselor of whatever level you want for free. No copay, no nothing. Go see them for free. And that's 10 sessions per issue. So you see them for 10 issues with your depression, and then you see them for 10 more for your issues of anxiety disorder. And now you know those categories, thanks to Allie. You can see them for every issue. You can get a bunch of free.
And so if it's marital counseling,
absolutely. My spouse has joined me for some programs that were put together by the EAP program. This is a great resource. It is free. You call up the number, they ask you where you are, they will send you an email of therapists you can see in the area that accept the EAP program. A lot of folks are doing telemed these days, whereas I'm not real happy about seeing my general physician. Telemed-wise, seeing my therapist, telemed was great. Did not have to drive, just set up the computer in my office, met with her every other week. It was wonderfully helpful. So I encourage you to look into those things. And let's see. You have got to make time in your life for self-care. You cannot let yourself get burned out, or else you are not able to serve Christ in the church effectively. So these connections are of vital importance. The people you've met here at Fresh Start, the people back around your church, professional things the diocese has to offer. That is what self-care is about. And when I see spiritual direction and when I see a therapist, that's on my working clock. That's part of my 40 hours a week, 40, whatever. Anyway, I do not have any problem in the middle of the day sitting in my office, in my church, taking care of those things, because that is part of your job. And your congregation needs to understand that your self-care is part of your job. They need to pay you to get your self-care that you need so that you can care for them and be their clergy. That's what I have for you.
Self-care, I'm doing Credo in June, so I know many of you know what Credo is, and some of you are not, but it got delayed from 2020. Finally signed myself back up.
Credo is a great program. Do not turn it down when the church pension group tells you you were eligible for Credo. Sign up. I've done my limit. I got my 2. I'll get my 3rd when I'm in a retired clergy category. But Credo is a great program. It's about self-care. Program 1 helps you in one way. The second program has a different curriculum and emphasis. So don't say, oh, I went to that. Say, I have another opportunity, and they'll talk about different things at number 2. So Credo is great self-care. Our pension group is wonderful in taking care of our clergy. Yes, Greg?
I actually did the original health faculty for Credo in the Presbyterian Church. And so it's really, it's powerful to see people come in and see them tired and worn out. By the end of the class, they have a new, viewpoint on health. And it's really powerful. But I also will say about the EAPs, we have a better EAP because they only have 6 seconds.
We do much better. So I just want to leave you really with have those connections with other clergy, mentors, coaches, spiritual directors. And one of the most important things those relationships will do is if you're starting to go down a bad path, if you've got a good relationship, one of your brother or sister clergy can say, Alan, it sounds like you're trying to do therapy with this parishioner you've now met with 8 times, and you need to go refer them because that's not good. That's not really the way we're supposed to spend money out of a discretionary account. There are all sorts of things that people can give you advice on that will keep you out of trouble in the Episcopal Church if you've got a good relationship with another colleague who understands where you're coming from. So foster those relationships, build those relationships, find those relationships, and maintain them throughout your ministry. Thank you.
If you ever have questions about those benefits, I cannot recommend enough
that you contact Pat Hawkins. She is the benefits coordinator for our diocese. I swear to God, I have emailed her, and as I hit send, the response is coming back to my inbox. I can't promise you that she will always do that, but she is extraordinarily responsive and the most knowledgeable person and the best, most helpful person to untangle that little card that Alan is talking about in your wallet. If you have questions about what can I do, what can my spouse do, what can my children do, she is the one to ask, And in many cases, she'll have the information right in front of her and she'll say, oh, you just call this number, or I'll actually ask for you. She's very good about that. So if you have questions about the self-care piece and how that meshes with church pension group and the church medical fund, and you're still not quite sure where to go, please ask Pat, because she will be delighted to help you. If she's not delighted, she sure seems like it, which is just as good. A huge thank you to Allie and to Greg and to Alan for being part of today's group. I can't think of a better note to end this Fresh Start semester group year than hearing about not only how we help other people and how to recognize these things in other people that we serve, but also how to recognize it in ourselves. And I do want to emphasize the fact that we are peers here. We are equals here. Absolutely. There is no reason why you can't email me or call me or each other or any of the other mentors, or Canon Izzo, who is also a wonderful resource for our clergy. She helps to care for us. I know that Rob Drosty is also always happy to talk to you about how to get involved in clergy triads or clergy coaching, if that's something that you feel would be important for your self-care and your mental health. I've never heard of or experienced a diocese that is so focused on caring for their clergy. And I'm not just saying that because I'm here. I'm saying that because I have colleagues in other dioceses where some of them really do feel like they've been left out in the cold, and we don't do that here. We're very intentional about not doing that here. And if that's what you leave this semester of Fresh Start understanding, I'll be happy with that. Any other questions about that before we
Have our lunch. And anyone who's here right now, there's lunch for you if you want lunch. So please take the opportunity to share lunch in this time with us. And without anything else, Bishop-elect Sally did say I could put her on the spot for praying for meals, and so that's what I'm going to do.
I'm even willing to brave the microphone again. The Lord be with you. Let us pray. Gracious and loving God, we give you great thanks for this opportunity to gather together today, for all those who have participated in sharing and connecting and building this community in this place. We give you thanks for the ministries you call each one of us to, and we thank you especially for the food that has been prepared for us. May it nourish our hearts, our minds, and our bodies, that we may go forth in Christ's service. In his name we pray. Amen.
Thanks all. Thank you. It's great to be with you.